I'm Dr. Lawrence Leiter, University of Toronto, and it's my pleasure to present on behalf of my colleague, Dr. Subodh Verma, also at University of Toronto, the results of the poster Liraglutide and semaglutide improve cardiovascular and renal outcomes across most BMI categories in type 2 diabetes, results of the Leiter and SUSTAIN-6 trials. Leiter and SUSTAIN-6 were previously reported large cardiovascular outcome trials that showed the benefits of liraglutide in Leiter and subcutaneous semaglutide in SUSTAIN-6 across both a predefined primary cardiovascular endpoint as well as a secondary nephropathy endpoint. Whether the cardiorenal benefits of liraglutide and semaglutide are consistent across patients with different body mass index categories is unknown, so we therefore performed a post-hoc analysis on both Leiter and SUSTAIN-6 data to evaluate cardiorenal efficacy by BMI categories in patients with type 2 diabetes at high cardiovascular risk. Here in Table 1, you see the baseline characteristics and the proportion of patients at baseline in each BMI category. We had categories of less than 25, 25 to 30, 30 to 35, or 35 or greater. And you can see that in both studies, the majority of patients had an elevated BMI, but we still had 8 to 9% of patients below a BMI below 25. The baseline characteristics were fairly similar across the BMI categories in both studies, although, again, in both studies, the duration of diabetes was somewhat longer in the patients with lower BMI. Here in Figure 1, you can see the cardiovascular outcomes by baseline BMI category. First, if we look at Leiter, you can see overall there is a significant 13% relative risk reduction in the primary MACE endpoint, which was MI, stroke, or CV death. If we look at expanded MACE, which also included coronary revascularization, hospitalization for unstable angina or heart failure, this was reduced overall by 12%, and CV mortality overall was reduced by 22%, all of which were significant. Now, if we look at the results across the various BMI categories, one sees fairly similar relative risk reductions with no significant interactions for any of these endpoints. If we now look at the results for SUSTAIN-6, overall significant 26% reduction for the primary MACE endpoint, 26% reduction for expanded MACE, which was also significant. CV mortality in this study was not reduced significantly, hazard ratio of 0.98. If we look across the BMI categories, once again, fairly consistent results with no significant interactions. If we now look at renal outcomes, and this was a predefined renal composite, including new or persistent macroalbuminuria, doubling of serum creatinine, end-stage kidney disease, or death from kidney disease, one sees a significant overall risk reduction of 22% in Leiter, 36% in SUSTAIN-6. Yet again, relatively similar risk reductions across BMI categories. We then looked at treatment differences in time to first MACE across continuous BMI using spline regression for Leiter on the left and SUSTAIN-6 on the right. The vertical lines representing the quartiles, and the majority of patients, of course, being in the relatively central part of this figure. And again, if one looks at it as a continuous variable, one sees relatively consistent risk reduction across BMI. In Leiter, when we look at SUSTAIN-6, the line is somewhat more variable, but remember that SUSTAIN-6 was a smaller study and we have fewer events across various BMIs. So our conclusion is that this post-hoc analysis from Leiter and SUSTAIN-6 show that the CV and renal benefits of liraglutide and of semaglutide versus placebo are consistent across baseline BMI categories, and these data reaffirm the cardioprotective role of liraglutide and semaglutide in patients with type 2 diabetes, irrespective of baseline BMI.